Hello friends, I am Professor Smita Jha from the Department of Humanities and Social Sciences, IIT Roorkee, and I am doing the course on health and disability in humanities. And under this umbrella term, today I am going to discuss attention disorder in health humanities, which is indeed a very important part of the course. So in health humanities, attention disorders such as ADHD are analyzed as socio-historical phenomena rather than purely biological deficits. And this is very important aspect. This interdisciplinary field combines literature, history, philosophy, and cultural studies to investigate how modern societal structures shape our understanding of human cognition and focus. By shifting the lens away from a strictly clinical diagnosis, the health humanities highlights several foundational concepts. The first one is the medicalization and history of distraction, scholars that includes tracing how the clinical parameters of attention disorders have shifted across different eras. They critique the medicalization of everyday life, examining how standard human variations in focus or physical restlessness were transformed into formal medical pathologies over the 20th century. Historical analysis often links the rise in diagnosis to the birth of mandatory industrial schooling and corporate environments that demand uniform, sedentary, and highly structured behavioral compliance. Second, the cultural attention economy, health humanities heavily interrogate the modern digital landscape. Instead of viewing focus issues purely as internal brain failures, scholars examine the external environment. They study how the modern digital ecology, characterized by algorithm driven social media feeds, push notifications, and corporate data monetization, actively fragments human attention, turning focus into a contested ethical and cultural commodity. Third is neurodiversity and narrative medicine includes centering lived experience rather than relying solely on clinical diagnostic manuals. Health humanities prioritizes patient memoirs, graphic medicine, and autobiographical narratives. Fourth is reframing deficits. These literary texts allow individuals to express their internal worlds, transforming the clinical concept of a deficit into the concept of neurodiversity. Now, this framework views attention differences as a form of natural variation with distinct cognitive strengths like hyperfocus and lateral thinking rather than a broken baseline. Health humanities brings together two perspectives that are often treated as opposites: the biological explanation and the lived experience. So, literary narrative reveal how individuals experience the level of ADHD and resist being defined by deficits, while neuroscience explains the neurochemical mechanisms that shape attention and executive functioning. Read together, these perspectives challenge the notion that ADHD is a behavioral failure and instead position it as a form of embodied cognitive difference. Further, the catecholamine system demonstrates that attention is deeply embedded in the material functioning of the brain, complicating simplistic distinction between normality and disorder. Thus, research on the connection between dopamine and the broader catecholamine disconnect explains exactly why attention disorder like ADHD are structural and chemical rather than behavior failures. Dopamine is not an isolated compound. It belongs to a specific organic chemical family known as catecholamines, which also includes uh, norepinephrine and epinephrine. In the brain, these chemicals are inextricably linked because dopamine served as the direct biological building block for norepinephrine. When a disconnect occurs in this system, the core issue is an abnormality in how these chemicals interact to manage attention, motivation, and external boundaries. The dopamine disconnect. So, the dopamine disconnect is the loss of internal value. Dopamine acts as the brain's internal currency for motivation, working memory, and reward processing. In ADHD, disruptions in dopamine signaling can weaken the connection between intention and action. The baseline deficit in an attention disordered brain, genetic variations often cause an overabundance of dopamine transports proteins that clean up chemicals from the neural pathways. This cleans dopamine away too quickly, leaving the prefrontal cortex in a state of chronic under arousal. The consequences is that because routine tasks do not trigger a normal baseline release of dopamine, the brain struggles to assign subjective importance or urgency to them. It enters a constant state of chemical searching, actively seeking out highly stimulating, novel, or chaotic tasks to trigger a necessary dopamine spike. The norepinephrine disconnect, the failure of the filter. While dopamine dictates what you want to focus on, norepinephrine acts as the brain's gatekeeper, managing the posterior attention system to filter out irrelevant environmental data. The dynamic failure in a neurotypical state, norepinephrine clears away background noise, so a single priority stands out. When a norepinephrine disconnect occurs, the internal filter fails. And the consequences is that background sound, passing visual details, and internal random thoughts are all processed at the exact same volume as the primary task. The brain cannot efficiently prime itself to focus on external intentional stimuli. Coming to the cultural norms and institutional power, scholars explore how systematic power structure influence who gets diagnosed. The schoolroom and the clinic are viewed as institutions that enforce normative behaviors. For example, the fields of sociology and health humanities note that the hyperactive impulsive presentation was historically designed around the baseline behavior of young boys, meaning that women, girls, and inattentive subtypes were long ignored, misdiagnosed, or forced to internalize their struggles. Coming to the medicalization of attention, the medicalization of attention is a core concept within the health humanities, describing the process by which variations in human focus, restlessness, and cognitive pacing have been redefined from social, moral, or environmental issues into formal medical pathologies like ADHD. By analyzing this shift, scholars in the health humanities critique the systematic drivers, historical roots, and consequences of viewing human attention primarily through a psychiatric lens. If we talk of historical drivers of medicalization, well, health humanities scholars trace how corporate and educational environments created the deficit. Some of the historical drivers of medicalization are as follows. First is industrial schooling. The birth of modern compulsory education required children to sit still, suppress impulses, and maintain uniform focus for hours. Behaviors that were acceptable in agrarian settings suddenly became disruptive pathologies. The Fisty Philip archetype. In 1845, German physician Heinrich Hoffmann published the poem Fitzgerald Philip, a moralistic tale about a restless boy. Over the next century, medicine absorbed these moral critiques, transforming naughtiness or laziness into a neurological deficit. The evolution of the DSM, sociologists like Peter Conrad note how the American Psychiatric Association continually expanded diagnostic boundaries. The level shifted from hyperkinetic reaction of childhood to attention deficit disorder, gradually broadening the criteria to include adults. The institutional and financial drivers, medicalization, does not occur in vacuum. It is propelled by powerful social institutions that shape how certain behaviors are understood and managed. In case of attention disorders, schools, healthcare systems, pharmaceutical companies all play a role in defining what counts as normal attention and what becomes classified as a disorder. Pharmaceuticalization. The massive rise in attention diagnosis directly correlates with the pharmaceutical revolution and the aggressive marketing of stimulant medications. Critics argue this frames a multi-layered behavioral experience into a simple chemical imbalance requiring a pill. Coming to the resource allocation, so in many contemporary school and workplace systems, a formal medical diagnosis is the only legal key to unlock support, accommodations, or extra testing time. This structural setup forces individuals to medicalize their experiences to survive in rigid environments. So you might wonder then what might be the first medical action in addressing the medicalization of attention. So addressability as the first medical action. A critical medical action analyzed in social sign process of whether to stay home or visit a doctor. This action is mediated by normative science, mental representation of what normal health looks like. When a person's current state deviates from these normative signs, it triggers a decision making process, often modeled as an analytic hierarchy process, to choose the best course of action. The structural critique of medicalization of attention tells us about the fixing the brain versus fixing the room. So, the health humanities challenge the premise that the problem resides entirely inside the individual's brain. The canary in the coal mine. Humanities scholars argue that widespread inattention is a rational human response to an increasingly fractured world. Instead of addressing system issues like underfunded classrooms, the erosion of physical play, or an exploitative digital attention economy, medicalization places the entire burden of adaptation onto the individual. Experimental vignette proof. Recent studies in the philosophy of medicine reveal that the public is significantly more likely to classify attention problem as a medical disorder if a genetic cause or a pharmaceutical cure is mentioned. If the exact same behavior is framed as a response to an environmental stressor like a toxic classroom, people view it as a social issue. This proves our definition of health are highly dependent on the solutions we sell. Vignette studies and conceptual philosophies. So, philosophers of medicine use health humanities to test what actually makes people classify attention issues as medical condition. Recent experimental vignette studies show that the public is far more likely to label to a focus problem as a disorder if it is attributed to a genetic cause or treated with a pill, rather than when it is viewed as a reaction to environmental stressors like classroom bullying. This underscores that our definition of illness is deeply tied to the solutions we prescribe. Coming to the resisting and reshaping medicalization, modern health humanities focuses heavily on how neurodivergent communities push back against top down medical definitions, from deficit to identity. So, on digital platforms, people are engaging in lay medicalization, taking psychiatric terms and stripping them of clinical coldness. They transform ADHD from a biological deficit into a shared cultural identity, emphasizing unique positive traits like hyperfocus, lateral problem solving, and deep creativity. Coming to a strategic medicalization, scholars observe that many individuals participate in a complex system of medicalization. They utilize the medical diagnosis to secure structural validation and workplace protections, while simultaneously relying on non medical frameworks like neurodiversity, communities, or executive coaching to manage their daily lives without feeling broken. If we talk of industrial schooling and the historical medicalization of attention, industrial schooling historically refers to two distinct educational concepts. The historical system covering 19th and 20th century. In the 1800s, government in Britain, Ireland, Australia, and colonial India established schools of industry or industrial school. Now, who were the target audience? Destitute, orphaned, neglected, or juvenile, delinquent children. And the philosophy behind is driven by the Victorian era viewpoint that poverty stemmed from laziness. The state assumed custody of these children to teach them to be industrious, so they would not grow up dependent on government aid. And the reality that these institutions operated alongside reformatories and religious institutions. Children were often subjected to harsh discipline and manual labor, such as shoemaking or tailoring for boys and domestic work or weaving for girls. 19th century system of coercive residential institutions were formed for neglected children, and modern trade or vocational education were designed to teach a specific manual, technical, and industrial skills. The modern system, which is a vocational and technical system, well, today the phrase is synonymous with the industrial education, trade schools, and vocational training centers. And the objective is to equip students with practical industry specific technical knowledge rather than abstract academic theories. And the curricula focuses on a specialized skill trade including mechanical engineering, electrical writing, carpentry, welding, automotive repair, and computer aided manufacturing. And the structure is often blends classroom study with hands-off apprenticeship program to supply local industries with a highly adaptable trained labor force. Connection to the factory model rhetoric. In contemporary educational debates, critics often use the term industrial era schooling or factory model school metaphorically. They use it to describe modern public schools that process students in standardized batches based on A's, utilized rigid AF grading system, and prioritize compliance over individual creativity. So, rhetoric of health and medicine is a specialized subfield within the health humanities that analyzes how language, symbols, and communication shape medical knowledge, clinical practices, and patient experience. While the broader health humanities often use literature or art to build empathy, rhetoric specifically investigates the power of persuasion, arguments, and discourse in healthcare. So, rhetoric in health and medicine reveals that medicine is not merely an objective biological science. It is a discipline heavily dependent on how information is framed, delivered, and negotiated. So, the core area of focus in rhetoric, health, and medicine, constructing disease knowledge. So, rhetoricians study how certain medical conditions are defined, categorized, and understood by society. For example, analyzing how shifting from the phrase addict to substance use disorder changes public stigma and medical treatment approaches. The power of metaphor. So, metaphors heavily influence patient psychology and health policy. The common framing of cancer as a battle or war can motivate some patients, but it can also induce guilt or anxiety in others who feel they are losing. Patient physician communication tells us about the examination, how power dynamics, health literacy, and vocabulary choices affect clinical interactions. Practitioners use rhetoric daily to convince patients to adhere to treatment plans or trust a diagnosis. Public health campaigns and policy. Now, under this caption, scholars critique the persuasive strategies used by governments during health crises, such as vaccine campaigns or pandemic lockdowns, to understand what drives public trust or resistance. Pharmaceutical and tech marketing. So, rhetoric in health and medicine evaluates direct to consumer drug advertising and the user experience design of digital health technologies, identifying how they persuade consumers regarding wellness and risk. Coming to methodologies used in rhetoric in health and medicine, researchers in this domain blend traditional humanities with social sciences using multiple tools. Zona analysis is studying specific formats of medical writing, such as clinical stimulation, scripts, electronic health records, or informed consent forms. Content analysis, assessing language patterns in public health literature. Ethnography, observing real time interactions between medical stakeholders in hospitals and clinics. Instead of traditional theory, heavy English departments, the vocational or applied approach to health humanities integrates directly into medical education through the following ways: empathy training via literature and arts. Medical students analyze narrative literature and even visual arts to cultivate keen observation, active listening, and a deeper understanding of the patient's lived experience. Empathy training via literature and the art is a core pedagogical approach in the health humanities. It targets a well known crisis in healthcare education, a documented drop in empathy that occurs as students progress through heavy clinical workloads and technical digital system. By training empathy as a malleable muscle rather than a fixed personality trait, health humanities program use novels, paintings, poetry, and theater to train clinicians to see patients as complex human beings rather than mere medical charts. Bioethics and public health, practical exploration of medical sociology, anthropology, and ethics teaches future clinicians how to navigate the social caste, class, and gender determinants of health. Clinical communication labs. Institutions are introducing applied medical humanities labs, such as India's first medical humanities laboratory at Bennett University, to practically bridge scientific knowledge with the emotional realities of suffering and disease. Structured storytelling and narrative medicine. This method shifts focus from a list of clinical symptoms to the patient's individual story. And the mechanisms is that students engage in analytical reading of fictional or autobiographical accounts of illness. Neurological fMRI studies show that reading about an individual's interior life triggers the brain's mentalizing system. This system activates biological pathways linked directly to pro social helpful behavior. And the clinical goal is it builds cognitive empathy and interpretative capacity. Practitioners learn to parse chaotic or vague patient histories, helping them find meaning in what a patient cannot explicitly state. Example action is that medical students read Leo Tolstoy's The Death of Ivan Ilyich to study the emotional isolation, denial, and social withdrawal experience during terminal illness. If we talk of visual arts and reflective observation, clinicians must notice subtle physical cues, but routine often blinds them to finer details. Visual arts training forces students to slow down and observe objectively. The mechanism speaks of as known as visual thinking strategies, VTS in short. Students are taken out of the hospital and into art galleries or labs. They are asked to look at complex paintings or sculptures for extended period, describing only what they see without jumping to conclusions. The clinical goal is this practice significantly increases perspective taking scores and reduces immediately diagnostic bias. It trains providers to separate raw data, what the patient looks acts like, from internal assumptions. Example action: reviewing painting like Luke Fells, the doctor to examine historical nonverbal dynamics of care, vulnerability, and clinician distress. Embodied simulation and theater, empathy requires more than thinking. It requires feeling and acting. And the mechanism rooted in the concepts of embodied cognition, methods like Augusto Boll's theater of the oppressed are used to make students physically step into the lives of others. The clinical goal, it speaks of physically enacting a scenario, engages kinesthetic perspective taking. This provides effective empathy training, allowing students to directly experience the power imbalance, anxiety, and vulnerabilities that patients feel. And the example action is role playing a scenario where a lower income patient faces systematic discrimination or a language barrier in an emergency room to uncover hidden biases. Poetry and reflective writing. So, medical education heavily favors precise evidence based data. Poetry teaches students to become comfortable with ambiguity, grief, and scenarios where there is no single right answer. The mechanism is writing or reading poetry forces students to distill complex emotional crises into precise, thoughtful language. The clinical goal, it serves as a safety valve to prevent emotional exhaustion and burnout. Processing grief through creative expression helps providers maintain a compassionate demeanor without succumbing to emotional fatigue. Now, let us discuss current challenges in implementation of all these. So, while data published in journals like BMJ Open and Medical Education Public demonstrate that over 90% of trainees find humanities modules highly relevant, and these programs face key bottlenecks. So, lack of standardization. There is a shortage of standardized, quantifiable tools to measure long term changes in clinician empathy. Curriculum crowding. In rigorous medical systems, finding dedicated time for arts and literature remains a massive structural challenge. Now, let us move ahead to discuss about medicalization of attention disorder and its connection with narrative medicine. That has already been discussed in detail in the previous lecture. So, in practice, a narrative medicine session moves sequentially through three steps that are developed at Columbia University. First is attention. So, the clinician practices absolute undistracted listening. They do not just listen for diagnostic symptoms, but also closely observe the patient's metaphor, tone, long pauses, and nonverbal vulnerability. Representation. The clinician processes what they have seen and heard by writing it down or mapping it out. Putting complex clinical encounters into language uncovers hidden details and underlying a structural theme. Affiliation. By combining attention and representation, a deep sense of trust and alignment forms between the caregiver and the patient, breaking down clinical isolation. Coming to the intersection of attention disorder and narrative medicine, so they tell us about that the intersection depends on which medical or health humanities framework you are using. Because negative medicine is not a single standard diagnosis, the term applies to three distinct concepts: negative defensive medicine, negative capability in narrative medicine, and negative medicine outcomes. So, narrative defensive medicine. In clinical practice, defensive medicine occurs when doctors alter their treatment to protect themselves from malpractice lawsuits. Negative defensive medicine specifically refers to avoidance behavior, such as doctors refusing to treat high risk patient or avoiding complex procedure. The conflict, the high risk attention disorder, that is severe ADHD paired with treatment resistance impulsivity, substance abuse, or severe oppositional defiance, require complex, heavily controlled stimulant regimen. The avoidance, due to strict state regulations on controlled substances and the legal risk of stimulant abuse, some practitioners practice negative defensive medicine by refusing to take on complex adult ADHD cases or declining to prescribe necessary first-line stimulant treatment, which leaves high-risk patient undeserved. Negative capability in narrative medicine. In the health humanities, scholars frequently discuss John Keats's concept of negative capability, the rare human capacity to exist comfortably in a state of uncertainty, doubt, and mystery without frantically reaching the immediate facts or single answer. The challenge: a neurotypical clinician's instinct is to rapidly check boxes, find order, and structure a patient's story. However, a patient with an attention disorder often communicates with a fragmented, nonlinear, or hyper-associative narrative style. The intervention and narrative medicine uses negative capability to teach clinicians to override their desire for immediate clinical order. Instead of viewing a patient's conversational stagnance as a diagnostic failure, the clinician utilizes negative capability to pay deep attention to the fragmented gaps. This allows them to listen to how the patient experiences their world without forcing them into a rigid box. Negative medicine outcomes. So, in pharmacology and public health, a negative medicine outcome refers to a patient experiencing an unachieved therapeutic goal, an entirely unnecessary treatment, or an adverse drug reaction. And adherence failures. Due to executive function deficit, individuals with attention disorder face significant challenges with medication compliance, that is, forgetting doses or losing prescriptions. This directly causes an MOs, negative medicines, so where the treatment fails simply because the disorder itself impairs the patient's ability to maintain the routine. The nocebo effect studies show that receiving a highly detailed negative warming information about mental health medications can cause severe anxiety in patients with attention dysregulation. This anxiety can cause them to hyperfocus internally, over analyzing minor bodily sensations and misattributing them as severe medication side effect. Coming to the addressing the nocebo effect and communication, the ethical challenge of informed consent is a central topic. The communication paradox: how does a doctor disclose risk without creating a nocebo effect? Ethical medical humanities explores positive framing as a way to fulfill the legal duty of disclosure while fulfilling the ethical duty to do no harm, premier no nausea. Empathetic literacy ethics in the field is often taught as literary training. By reading fiction, medical students develop empathetic imagination, allowing them to ethically navigate gray areas where clinical guidelines provide no clear answer. Well, this is all for this lecture on attention disorders. In the next lecture, we shall examine how the structural friction discussed in this lecture in terms of the medicalization of attention disorder registers somatically and culturally in another disorder, anxiety disorder, thus shifting our focus from how society policies attention to how society disables through anxiety and how it connects to health humanities. Till then, thank you very much.